going to talk about the physiology of, we'll get this far enough away and put my mask up. Physiology of lung injury. So it's not a talk about treatments. We're going to kind of deep dive into the physiology of ARDS, acute lung injury, and hopefully these are things you can take away and think about at home. So, I mentioned this already. So ARDS, so the Berlin definition of ARDS, which is the standard definition, timing is important. So the insult that we're trying to call ARDS has to happen within a week of the known respiratory symptoms. You have bilateral opacities. The edema, the type of edema is important, right? Because just because you have edema or consolidations or infiltrates bilaterally, it does not mean that it's ARDS. The definition of ARDS has to have some sort of inflammatory component to it, where there's capillary leak at a lower hydrostatic pressure than what if you had hydrostatic pressure-based, congestive heart failure-based pulmonary edema. So the old definition actually had measurements with a PA catheter and wedge numbers that you would have to follow to call this ARDS. That changed over time, and now we can use echo non-invasive modalities to say that this is non-cardiogenic rather than cardiogenic pulmonary edema. Right? And then we all know about the P to F ratios, right? So it helps kind of break down not only just kind of like in our head structurally, but prognostically. So we have mild, which is P to F of less than 300, moderate, less than 200, and severe, less than 100. And we throw these numbers around all the time because we're saying, am I going to prone this person? Am I going to use paralytics? Like, so management really changes when we're talking about P to F. What I want you guys to really kind of notice is that there's a PEEP definition in there, right? So if someone with a P to F at 250 at a PEEP of 5 versus a P to F of 250 at a P to F of 15, those are different people in my head, right? Severity is different in my head. So there's limitations to these definitions. These are basic definitions, but it's up to you to understand the physiology and make sure that you're comparing apples to apples rather than apples to oranges. Okay? And from what I understand, the last definition did not have PEEP in as a definition, and which I thought was a limitation in that definition because, as you know, with positive pressure, you're more likely to have more open alveoli to a certain extent, and your P to F at any given level will be different. So these are kind of the main things that changed from before. Even with these definitions, our ability to recognize and manage ARDS for the things that we know that work, like low tidal volume ventilation, is actually still very poor. You could have the bilateral infiltrate, you could have the definition, they meet all the criteria, but we often don't recognize and say we should be managing them as if this is ARDS. So that is just very basically, we're saying was when the ARDS I mentioned, this is non-cardiogenic pulmonary edema. Doesn't mean that it can't have a cardiogenic component on top of that, but there's at least a non-cardiogenic pulmonary mechanism that's causing capillary leak. So you have something that's leading to pulmonary endothelial permeability, some sort of inflammation. Let's say pancreatitis. You have a diffuse surge response, diffuse inflammatory response, and your capillaries are leaking. Same thing with sepsis. So that initial insult, risk factor, inflammatory response, the insult, and that leads to alveolar flooding. And then these are all the normal kind of sequelae that you would see in these patients. Now, the part that we really have to keep in mind once we intubate these patients, so you have the alveolar flooding, you have surfactant abnormalities, atelectasis, hypoxia, but then we put them on mechanical ventilation. This is where they are at risk for ventilator-induced lung injury. The reason why we really focus on low tidal volume ventilation is that we want to minimize the iatrogenic injury that we're causing to that patient. Positive pressure ventilation is not normal physiology. It's completely different from normal physiology. Normally, when we're breathing with negative intrathoracic pressure, right? In positive pressure ventilation, it's positive. The lung is not used to all those positive pressure breaths that we're putting in every second, right? So they're at risk for ventilator-induced lung injury, and we have to try to minimize that by understanding physiology and just doing the basic things like low tidal volume ventilation. So I just put this you don't have to look at this and understand this, but I just want you to show that ARDS is a syndrome that's heterogeneous, right? So remember that it's heterogeneous. We're saying that ARDS is the fish, but then within the fish criteria, there's going to be swordfish, there's going to be sharks, there's going to be, so remember it's an overlapping definition, but the etiology is innumerable, right? There's a lot of difference. Once you say this is ARDS, you need to try to figure out what caused that ARDS because the treatment can be different. It's a very heterogeneous condition, just like sepsis, right? Sepsis, we say something is sepsis, but it has many, many different etiologies, and treatment can be slightly different with each one. And this may be why it's tough to get positive trials with ARDS for treatment, because it's tough to really get down to that more complex taxonomy saying, we're saying this is the ARDS, but there's so many different etiologies that cause ARDS. And that's why treatment may not work on one patient, it may work on another. So this is the classic picture for ARDS. So you're only seeing the bilateral infiltrates. Now again, looking at this, you can't tell if this is cardiogenic or non-cardiogenic. This is where the non-invasive and previously the pulmonary artery catheter came into it, try to distinguish the two. All right, so let's kind of get our brain warmed up a little bit. Like I mentioned, this is not a treatment talk, this is a physiology talk, but I want to make sure that we're all on the same page as far as definitions and at least basic treatment, right? So you have this patient, comes in with ARDS, you intubate them. What are your initial ventilator settings going to be? So let's kind of go through this. I'll give you 20 seconds and we'll take a vote. So, how many of you say A? You got one for A. How many of you say B? Awesome. Okay. What about C? Anyone for D? No? All right, so the answer is B. And the B, reason why you choose B, so Lindsay, why did you choose B as opposed to A?
So going through like each of them, so looking at the cc's per kg, so it would be acceptable to have 6 cc's per kg, but lower would be better, so 4 to 6 cc's would be better. And then titrating P for optimal compliance, for frontal less than 30, that's much better if you're getting to optimal compliance. And then definitely B is better when it comes to maintaining oxygen saturation greater than 92%, but not keeping it as high as possible. And then the last one would be essentially reflecting like permissive hypercapnia. Both of them are similar, but B would be more acceptable.
Perfect. Awesome. I think where we kind of missed the mark a little bit is that we're content with 6 to 8 when we should be shooting for 4 to 6, right? 6 is the minimum that you want to shoot for. And where we often have room is here. Right? So we see a pH of 7.25 and we say, I have permissive hypercapnia, but I don't want to make them more acidemic. So we can tolerate lower pHs. Lungs actually do pretty well with lower pHs. So if your pH is 7.25, I can say I have room in Tidal volume, right? I have room in respiratory rate. So tidal volume is the first thing that needs to come down, right? So if I'm at 7 cc's per kg and my pH is 7.25, I'm saying, well, it's about 7.1, so I can drop it even further. So I'll try to get to 6, try to get to 4, try to get to 5, 4, and onwards. Right? Make sense? That's the basic management issue. And the key, there's a term that I forgot who came up with this term called euboxia. And basically, we try to normalize everything, right? We don't need to normalize every number, right? The body is sick, it's critically ill, it can handle hypoxia relatively well, and it can handle acidemia relatively well. So better oxygenation, 100%, doesn't necessarily mean you're going to do better, right? And oftentimes, it may actually lead to worse outcome. Okay? All right, now the fun part. let's talk about physiology. So a lot of these slides, if you guys want to look at later or some of the lectures, it comes from John Emil Kenyon's website, heartlung.org. And he's kind enough to let me use his slides as I choose. So, but great website, and you have any questions about this afterwards, you can go onto the website and get more information. So let's kind of simplify the lung respiratory system. So we have someone who's intubated. We are putting air in. So these are 3 separate lungs. Now, your respiratory system is made of your lung and it's your chest wall as well, right? So you can have a situation where you have low compliance ARDS. You have your plateau pressures are very, very high, and it can be the lungs rather than the chest wall, right? It's the lungs that are swollen, edematous, boggy, and you're putting the air in, and that's the reason for most of the compliance issue rather than the chest wall. This is normal, right? So you have the thin-walled lung, and your chest wall is normal as well. On the other end, the lung can be relatively okay, but it's the chest wall component that's leading to the poor compliance. Can you guys think of an example where it could be here? Where the chest wall is causing some to most of the compliance issue. And you're getting plateaus of 35, 40, and you're having a difficult time coming down in Tidal 1. What's an example that can contribute to that?
Obesity.
Obesity, yeah. And we've gotten very, especially during COVID, we've gotten really good at taking care of patients who are obese, and their physiology is different, right? But we could say, if I have 2 plateau pressures, I have a little old lady, and her plateau is 30 at the same tidal volume. And then I have someone else who's 400 pounds, and his plateau is 30. Which lung am I more worried about? So think about it from this perspective, right? So I can tell you, so the little old lady, which category do you think she fits into? Could she have a big chest wall component? No, right? So most likely, her lungs are the primary problem, and that's intrapulmonary ARDS. The lungs are boggy, swollen, and that's the problem there. On the other side, the morbidly obese patient, there may be a lung component, but I know for sure that there's going to be a chest wall abdominal component, right? And so this is where the morbidly obese patient would come into it. So what you have to remember, and we'll touch on this for a second. So you have to remember the concept of transpulmonary pressure. So your transpulmonary pressure is equal to what you're putting in your transalveolar pressure minus the pleural pressure, right? And so what you want to think about is this is what you're seeing on the screen. This is the plateau you're seeing on the screen, right? This is the pressure you don't know about. You can estimate that with esophageal manometry. And if you put an esophageal manometer in, you can get an estimate of the pleural pressure. So this is an unknown, but I can guess that the 400-pound patient's pleural pressure is going to be really high, right? So if I know the 400-pound patient's pleural pressure is really high, but the plateau is the same between the little old lady, my transpulmonary pressure is going to be a lot lower in which situation? The obese patient, right? The damage happens because of this. So at any given tidal volume, any given plateau, I'm more worried about the lungs of the little old lady than the morbidly obese patient. Does that make sense? Right? So not all plateau pressures are created equal. You have to look at the context of the patient itself. Right? Questions on that? That's an important concept. Ready? All right. So just another cartoon to illustrate what I was just talking about. So this is your lung. When you're spontaneously breathing, you're breathing at negative intrathoracic pressure, right? So I'm taking a breath. I'm creating negative pressures in my pleural space. That negative intrathoracic pressure is what leads to flow, because my atmospheric pressure will become higher than my intrapulmonary and intrathoracic pressure. And that's what leads to air coming in. That's spontaneous breathing. In positive pressure breathing, it's the opposite. So we're pushing air in, but this will be positive, this pleural pressure, right? And then what adds to the pleural pressure is the chest wall component. The more ascites you have, the more obese you are, if you have scoliosis, someone sitting on your chest, all these things are going to lead to worsened chest wall compliance. And my transpulmonary pressure at any given plateau is going to be lower. I'm less nervous when I see plateaus of 32 on a 400-pounder than I am in the little old lady. So this is the Campbell diagram. Now, we don't have enough time to really get into the details of this, but when I'm thinking about pulmonary physiology, this is kind of what I'm trying to construct in my head. So let's kind of like understand what all the axis means. So these are your airway and pleural pressures here, right? So as I mentioned, in spontaneous breathing, it's negative pressure, right? This is the elastance or your stiffness of your lung. This is your elastance and stiffness of your chest wall. The chest wall wants to come out, the lung wants to collapse in. And so interposed and connected to each other, this is your functional residual capacity. Your capacity of air in your lungs at rest, right? So this is your FRC. Now, if I make a patient have ARDS and their lung function, I'm going to be shit. This whole system, all these curves will change, right? So this is the net respiratory compliance and net respiratory elastance of the whole respiratory system. This is harder to think about than this, but you can interpose the two, and this is what the net will be. Now, if you end up having ARDS and your lungs are stiff, this curve is going to shift over and downwards, right? So it'll look more like this, right? Because the way you want to think about it is that at any given volume, my pressure is higher, right? So that tells you that my elastance or my compliance is poor. I put 1 cc of air in, my pressure will rise more in a low elastance lung than in a normal lung, right? And so this is how it will shift. So this is normal, right? But if I shift this over, can I tell if it's pulmonary ARDS or extrapulmonary ARDS or lung versus chest? No, I can't, right? So that's where esophageal manometry and then your clinical judgment, going back to the 400-pounder and the little old lady, your clinical judgment can help you estimate which components are high at least, right? So you know at least in the obese person that the chest wall component will be high. So in this one, so in the extrapulmonary ARDS, you can see that the curve, the theoretical curve, you can't tell the difference. But if I could somehow find these and actually have the knowledge of these, the chest wall component will shift over. Okay? The chest wall component will shift over, and the whole net respiratory system compliance will worsen. Okay? This is difficult, and it's not always intuitive, but I would really suggest you to sit down, get a whiteboard, draw these out, and create different pathologies in your head, and just see how the curves change with the two, because it's really helpful. This makes rapid shallow breathing intuitive. This makes why proning works intuitive. If you really understand this curve, you don't have to memorize anything. You can intuitively work through the physiology of most disease processes. Right? So that's the Campbell diagram. So let's start getting into some of the terminology that you'll need to understand for the pathology of lung injury. So we talked about the transpulmonary pressure already. Now, I know Dr. Bartok and Dr. Damith have been doing ventilator rounds with you guys. So for the second years, this might be old news for you. But for the interns, residents, first years, this may be new terminology, but it's important to understand. So let's start with strain. Now, to understand strain, you have to understand the concept of the baby lung, right? So I think it was Dr. Cresoni or Dr. Gananone who kind of coined the term the baby lung. So what they found, let me see that. Here you go. So in the baby lung, what they were saying is that we think in our head that in ARDS, there are stiff lungs. In actuality, the elastance of the lungs itself as a whole don't change that much. It's just the size of the lung that gets smaller. Your FRC, your functional residual capacity, is far less than what it was in health. So there's a term called the specific elastance, which basically describes how stiff is your lung exoskeleton. That stays pretty constant. You're just decreasing the number of lung units available for gas exchange, right? So hence the baby lung. So the baby lung concept is important when you're thinking about stress, strain, and they're very related to each other. So to understand strain, you can think about it is that if you had two patients, so you had a patient with ARDS and a patient with normal lung physiology. Now, if I put 400 cc's into the patient with the baby lungs, I'm putting a tidal volume that's twice as big as what that person's functional residual capacity is, right? So my strain is 2. In this situation, in the health, my functional residual capacity could be 400, and I put in a tidal volume of 400, my strain is 1. So why do we do low tidal volume ventilation? We're hoping is that with low tidal volume ventilation, if we have this, we can minimize, at least with a higher probability, how much strain we're causing on the lungs, right? High strain over time will cause damage. So we're kind of guessing their FRC, and we're trying to give them low tidal volumes because we're assuming that they have a baby lung and their functional residual capacity will be very low. That's strain. Questions on strain? Stress is proportionate and related to the two. Now, and we'll look at the equation later, but strain and stress are pretty proportionate to each other. So when the surrogate that you want to use for strain is just your transpulmonary pressure. So your transpulmonary pressure, your stress, your transpulmonary pressure, how much alveolar distension you're having is your surrogate for your stress. So the more distended, the higher your transpulmonary pressure. The little old lady had a higher transpulmonary pressure, higher distending pressure, and therefore had more stress. So over 48 hours, if I keep pounding those lungs with those tidal volumes in someone who has a very small FRC, I'm going to get more hypertrophic lung injury over time as compared to the more obese person. Right? Make sense? So that's strain and stress. Driving pressure is something that so COVID made driving pressure normal terminology. It just blew my mind. I was at Inspira, and the intern was presenting to me about the driving pressure of the patient, and I just couldn't believe it. And so COVID made this a normal terminology because we saw so many patients with stiff lungs, and ARDS just became so common. So driving pressure is the difference between your plateau pressure and your peak, right? And so essentially what you're doing there is you're adjusting your tidal volume for the total compliance of your respiratory system, right? So if you have very, very compliant lungs, you have a balloon that stretches very well, at any given tidal volume, your driving pressure will be low, right? And the way we use this oftentimes is when we're trying to find the best peak, right? We use this, say, okay, my driving pressure is 12 right now at a PEEP of 5. I increased my PEEP to 10, and my driving pressure is now 8. What that tells me is that at any given, I didn't change my tidal volume, right? I didn't change my tidal volume. All I did was I potentially recruited more alveoli, increased my compliance, and therefore reduced my driving pressure. Make sense? You're essentially just telling me is that I improved my compliance with the PEEP. Now, if you told me the opposite scenario where I went from a PEEP of 5 to a PEEP of 10, and my driving pressure went from 12 to 22, what are we doing there?
Just causing stress and strain.
Stress and strain and overdistension, right? So we are working against ourselves there, right? So that just tells you that at that PEEP, we've overdistended and the pressure is going up exponentially, right? So we got to kind of back up on the PEEP there. Now, those concepts, I think we are probably on the same page for now. Let's step it up a notch, right? I think you're ready for this. We're going to talk about,
I have questions.
Yeah.
When we do our ventilator run, when we measure driving pressure, we measure it from the PEEP that is set.
Okay.
But some people have told me before that it's actually total PEEP.
Of the total systemic PEEP.
Correct. So like if you do like your aspiration,
Sure.
pause, and then you get your PEEP.
How much intrinsic PEEP would you expect in someone who's not auto PEEP?
In most cases, like
Minimal, right? That's what I would say to that. Is that I am assuming that I've set the ventilator correctly enough that my auto PEEP is minimal, right? So that's what in reality, what you're saying is true, but I would assume that it's negligible because auto PEEP should be so low, right? Mechanical power, right? So we talked about, so when you have the scenario where, man, my oxygenation isn't very good, my pH is now 7.15, but my tidal volume is 8. What am I going to do here, right? And oftentimes, what I did was that we'll take the oxygenation part out of it. That's confusing. So my pH is 7.15, and my tidal volume is 8, and I'm reaching my limit on what an acceptable pH is, right? I drop my tidal volume more, what's going to happen to my pH? Go down more, right? So then I'm hitting my limit. Now, what I did was I go up on the rate, right? And I don't even think about it. I don't think about it. Or sometimes if I have enough oxygenation, because for oxygenation, if this is your pressure, so this is your PEEP and this is your pressure, your oxygenation is proportionate to your area under the curve for your pressure curve. So this is why APRB works for oxygenation, because essentially you're taking this and you're doing this, right? You're increasing your I. It's inverse ratio of ventilation. Your E time is really small and your I time is really large. So if my oxygenation is okay, my sats are 96, 97%, and I have at any given I time, and I want to improve my ventilation, what can I do with my I time? Reduce it, right? My oxygen is good. I don't need this area under the curve. So I could do this, and this might be enough for my oxygenation. Now, what did I do to my E time when I did that? Increased it. That leaves more time for ventilation, right? So lowering my I time, because I have oxygen, you're playing a game. You're just playing a little games and knowing all the strategies to where I can give and where I can take will really help you understand the nuances of how you can adjust things, right? So I dropped my I time, my oxygenation, now my stats 94%. I'm still happy with that. My pH is 7.18. My tidal volume is still 8, right? What can I do? I can increase my respiratory rate, right? I can increase my respiratory rate. And I used to think that there's no problem with that. Well, turns out, just like everything else I've ever studied in my life, things were a lot more complicated than meets the eye. So increasing your respiratory rate has its problems, which we'll talk about.
Wait, just a quick question.
Yeah.
For ARDS management, do you, I guess attendings in the room, have like sort of a speed limit in mind for rate that you don't go above? Whether it be 35 or...
I don't have a number. 30, when you're hitting 35, you're hitting that high, you're probably getting to the point where you're going to be starting to auto peak.
Yeah.
And yeah, so you're probably going to be hitting your limitations there. But that depends. So every question you're going to ask me, I'm always going to say it depends, right? Because you have to take into account what the time constant is for that patient's overall respiratory system. I'm not talking about time constant, but I'll quickly go through it. So basically, time constant is, all it is if you have a respiratory system, how long does it take to fill up that lung, right? Or how long does it take to empty that lung? And basically, so you have 1 time constant, 2 time constant, 3 time constant. And so the way you figure out what your time constant is, what this is basically equal to your resistance times your compliance, right? Now, in ARDS, this is horrible, right? This is horrible. And my time constant will reflect that. Now, if you have an obstructive component, your resistance could be high. So it depends on those lungs, right? How quickly do those lungs empty and how quickly do those lungs fill up? So to that question, it depends. Now, empirically, what I've seen, and Dr. D, please interject if you see anything else, is like when I'm starting to hit 35, I'm hitting my limit there. So, make sense?
Yep, thank you.
And time constant is something you guys should look into because it's an important concept to understand. But we just don't have time to review that in detail right now. Now, let's go back to stress and strain just a little bit. I think this equation and this kind of relationship really kind of cemented it in my head. So I told you that stress is related and proportionate to strain, right? So stress, which is high transpulmonary pressure distension, is what leads to barotrauma. The strain, which is your tidal volume relative to your functional residual capacity, leads to multi-trauma. Both these things are bad, and they're both proportionate to each other. So we already talked about that stress is proportionate to transpulmonary pressure. Now, how does transpulmonary pressure relate to strain? Now, strain can be looked at by, like I said, your tidal volume divided by your FRC. If your FRC is low and you're putting a tidal volume that's 400 and your FRC is 100, your strain is 400. That's really bad. It's really bad. Now, this constant, this K, is basically what I was talking about before, which is your specific elastance of every lung tissue in the world. If you were to look at the elastance of an individual lung unit, what is that stiffness? It's around 12. And I forget what the unit is, but it's around 12. And so this actually keeps me, I actually try to just do a little algebra, try to work back and try to see what this strain will lead to and what kind of stress, and vice versa, right? And you can actually go and kind of estimate your FRC that way too, right? So if I know that my transpulmonary pressure is 30, which is really high, I know I'm putting a tidal volume in of 400, then it's just simple algebra, right? Because I know what the K is, I know what the tidal volume is, and then you can figure out what your FRC is. Does it change your management? No, but it really cements how extreme this ARDS is and how small and how baby lungish this ARDS is. Okay. So this is, I don't want to spend too much time on this because you really have to be caffeinated to really want to appreciate this. So mechanical power, just kind of like to visualize, we can don't look up here, just look down here for now at the equations, right? So this is kind of intimidating. So this is the equation for mechanical power. All I need you to look at is look at the important variables that are in there, right? Now, respiratory rate is in there. You guys see that? So respiratory rate, if I increase my respiratory rate, I'm going to increase my power. And I'm already telling you guys that power causes damage. But look at the tidal volume. My tidal volume is squared. So every cc of tidal volume that goes up, or 2 cc's, I'm squaring that. So there's an exponential increase in power with tidal volume that doesn't happen with respiratory rate. So I go back, and when I increase my rate, I don't like it as much, and I don't think it's that safe anymore, but I'm more okay with changing my rate than my tidal volume, because tidal volume is a big, big driver in your overall power. Now, look at this side. So your delta velocity and then your delta tidal volume, PEEP is in there too. So if you're at a higher PEEP, that's higher mechanical power, right? And so theoretically, this is why you always say the lowest PEEP to get the job done and to get optimal recruitment, right? You don't want to overextend because it has its own problems, but there's the mechanical power is high. And I'm going to show you in a little bit that power also causes damage. So let me introduce this concept of inhomogeneities. So the word is a word jumble. So I'm going to be saying it a lot. So inhomogeneity. And it was coined by Dr. Crisoni. And it's basically, if you were to take 2 perfectly clean lungs with no pathology, there is 0 inhomogeneity there, right? Now, let's take those perfect lungs and I start putting patchy infiltrates, consolidations, edema. Now, there's more tissue in that lung that's not homogeneous with the rest of the lung, right? That increases my inhomogeneity. Why is that important? So what they found is that the more inhomogeneity you have, the more stress at any given tidal volume you're going to cause on the healthy lungs. That's going to lead to more inhomogeneity. So it's a vicious cycle, right? It's going to be a vicious cycle. And that, I'll show you an illustration that really kind of cements that. So this is like, I was going back to the baby lung concept, but let me find the image that I was talking about. So stress gradient. So when you have inhomogeneity, so let's say this is a normal lung unit, right? If I put in a tidal volume, that pressure, that strain, that stress will get sent proportionally to all parts of that lung unit. Now, let's add some inhomogeneity. I'm going to cause someone who's supine and they're developing pulmonary edema. Most of the pulmonary edema will be there anyways, right? Supine will be more dorsal. So at this intersection, I have some parts of the lung that don't look like the healthy parts of the lung. And so this is the swollen edematous lung unit. And now I put in the tidal volume. What it's going to do is that it disproportionately causes distension of the healthy, right? So if you can imagine, if I multiply this times thousands and it's getting worse over time, I'm going to get this picture in more units. And the more units I get this picture, these capillaries that are here are going to get damaged and become more swollen and be more edematous. So it's going to be a vicious cycle, right? So inhomogeneity, very, very important concept that I don't think we talk about. We don't have to talk about it, and I think it's intuitive that we all understand. The worse, the more infiltrates the lung has, the worse it is. But you have to understand that the more infiltrates your lung has, you have to be more careful. You have to be even more careful with every cc of tidal volume you're putting into that body. Right? Make sense? Go back. Actually, let's talk about this one. So, still sticking to stress, strain, homogeneity. So, if you take, with the stress-strain relationship, at a strain around 2 is when your stress shoots up. So when they look at mortality, your strain above 2 is when your mortality also shoots up. So if you're putting in a tidal volume of 400 and an FRC of 200, you're causing damage there, right? So you want to try to get that down to as close as your functional residual capacity as possible. And we talk, again, this is the same illustration before. healthy lung, apply volume, everything the same here, the stress razor. This doesn't change that much, but the healthy lungs are getting over distended and they're going to become damaged over time. Okay. Now, we talked a little bit about the baby lung, and I'm going to bring in, so I talked a little bit about PEEP. I talked a little bit about inhomogeneity. I mentioned proning. I'm going to try to bring it all together. So this is a healthy lung, right? So the way our body, way our lungs are kind of shaped is there's a shape mismatch between your lungs and your chest wall. So the way when you're squeezing the lungs into the chest wall, this ventral area is actually more open and larger and more able to have gas exchange than this dorsal area. And gravity may have an effect on that, but actually I heard John Emil say that they simulated this in zero gravity with pigs, and it actually looked very similar still. Right? So gravity, my explanation would have been like you're lying back there, gravity and heart and all that stuff's making a difference. But this is also true at zero gravity. So this is where the shape mismatch theory comes from, is that you're squeezing in a round thing into something that's conical, right? And so it's going to fit wherever it's going to fit, right? And there's going to be discrepancies. So, and this goes back to like evolution and teleology. Like, why did you evolve like this? So one of the working hypotheses is that we weren't always biped. For most of like the evolution of our lungs, we've been like before us was quadruped, right? And so this, if you're on all fours, this is optimal way for the lung to evolve, right? So there's some anthropomorphicity when we think about why, like,
It was all a matter of time.
So that's kind of why certain maneuvers like proning or PEEP will work, right? So if you apply PEEP here, you may reduce some of the inhomogeneity, and you reduce the number of stress razors you have, and you reduce damage over time. But that's only to a certain extent. And remember, your mechanical power is going to go up when you go up on your PEEP too. This is what makes me love proning even more. You don't change anything about your mechanical power, right? You're basically getting a lot for nothing, both financially and physiologically, right? You're getting a lot for nothing. And so here, you can tell, if I tell you that there's no aeration here, there's all the edema, consolidations posterior, I flip them onto their belly, this will change. So I have another picture where it kind of shows you what the pronon is, and I'll show it to you guys in a second. But if you imagine, if you're flipping them over, you're going to start recruiting more of the dorsal area, the lung, the heart's compressing on that area less, so you get more recruitment here. And now, if you're laying on your belly, blood will go where? Based on where gravity goes, right? So now it's going to go ventrally. Before, blood was going dorsally in non-aerated area. So you're improving VQ mismatch, you're improving inhomogeneity, reducing stress razors, and you're not adding more mechanical power, right? You're getting something that's nothing. This is why I love proning. It's just physiologically really elegant and relatively simple and cheap to do. So bringing back the inhomogeneity concept, which we'll keep coming back to. So let's take that patient I was talking about there in ARDS. We already talked about that dorsally. Most of the inhomogeneity and consolidation is happening, right? So to illustrate the inhomogeneity, so let's break the lungs up into different zones. Zone 1, Zone 2, Zone 3, Zone 4. Now, we all have kind of like talked a little bit about the pressure volume curves, but let's kind of like go through it a little bit. So here on the x-axis, you have pressure, and on the y-axis, you have volume. And I'm increasing my pressure, or I'm increasing my volume, whichever way you want to see it, is that now I'm getting a rise in volume. You see, at this point, this lower inflection point, I'm getting a lot of volume change, but very little pressure change, right? So I recruited more lung there, And now I'm getting a lot. So basically you're giving 10 cents, but you're getting $1 back, right? So this is where above the lower inflection point, you recruited enough where that every cc of tidal volume you're putting in there, your pressure is not changing much. So that means you're recruiting at the same time. You're getting more alveoli as you're adding air. So you should have, ideally, in a homogeneous lung, a very similar looking one, like this, or basically one loop. Now, in something like with ARDS and high inhomogeneity, it'll look like this. Each one has different, right? But I'm putting tidal volumes in, assuming there's one lung unit. I'm causing so much damage in this area, right? Okay, so we beat the concept of stress raisers. So everyone understands stress raisers. So the other part I'll point out here is that if you're increasing strain and stress, so I told you that, so the more stress you have, the more RV afterload you're going to have as well. Because if you can imagine, if this is happening, I'm compressing my capillaries too, right? So my RV afterload will increase. My RV afterload increases proportionate to my transpulmonary pressure. If I can reduce my transpulmonary pressure, I can reduce my RV afterload, right? And so proning can help reducing your RV afterload. And this is why if I'm hedging on proning someone and they're pitted after the borderline, if I look and see that there's increased RV-LV ratio, that pushes me over and say, I'm going to prone early, right? And it's amazing how often you'll go from 2 pressors, 3 pressors to 1 or off. It's incredible to see. So talked about this, the 2 main mechanisms for reducing inhomogeneity. The other thing on this is diuresing, right? Diuresing will probably, if you have some cardiogenic component to your pulmonary edema, which most of our patients will, your diuresing the patient will increase the homogeneity of the lung, right? So proning, we talked about, but we're not getting anything, there's no free lunch here. You're losing something and all about adding more mechanical power, and you'll probably be increasing RV afterload more than you'll be gaining as far as improvement. So your transpulmonary pressure may increase if you incorrectly put your PEEP. I'm sorry, your PEEP right here. But the proning is something that you get for free, and it improves VQ mismatching and then the gravitation-related things that we talked about. Okay. So I talked a little bit about the pleural pressures. So this is an esophageal balloon. So how do you actually measure your pleural pressure? You put an esophageal balloon in. It's literally just kind of like an NG tube or an OG tube. You put it in, you inflate the balloon, and it has a pressure monitoring system. And you're able to kind of estimate your intrathoracic pressure, your pleural pressure. It's not a perfect system. And what I found is there's just a lot of, when you put it in, you always think it's going to work better than it does, kind of like a swan. Like it's going in, out, where's the position. It's just like, when we do the swan, I'm all excited, we're going to get the numbers. And then I get sick of it in 24 hours because it's like, we're not able to wedge, we're not able to, same thing with this. I found it's just like, and whenever we use this, luckily, there's one guy who, in fellowship, his whole research was on this. So he would just come to the bedside and tweak it without us having to come all the time. So that's the only reason why I ever used it, because I didn't get the call for this. But it's really, really helpful when you have a morbidly obese person. So if you were to talk, we talked a little bit about so it is about transpulmonary pressure in the end. There's one trial by Dr. Talmor who looked at transpulmonary pressures as their main. Basically, they looked at transpulmonary pressures to see if they can reduce ECMO and improve mortality, because patients were transferred over for ECMO. And what they found is if they used their protocol, as opposed to the Artenet table, they used their own transpulmonary pressure table. And using that transpulmonary pressure table, they reduced how much ECMO was needed, and there was an improvement in mortality. The trial was not that big. It has not been recreated, but it's physiologically rational as well. So I would believe this. I think anyone have the questions on driving pressure anymore? You're okay? 'Cause we're using the terminology a lot. I just want to make sure everyone understands driving pressure. Okay. So for you just to understand some of the damage that mechanical power can do over time. So there was a study they did looking, I can't remember what the animal was. And they basically kept the peak and tidal volume constant. So let's say 200 cc's for a bunch of rabbits. And then they increased the respiratory rate in one group. So they increased the respiratory rate. So the much higher respiratory rate group had more progression of this over time. So the lungs went from this to this. So mechanical power, remember it's a problem, and also velocity. So one thing I didn't mention is in this situation, if I'm reducing the I time, my velocity is also increasing. So I used to think that peak pressure don't matter, but peak pressure is a reflective of how fast your velocity, your airflow, how much turbulence there is. So that matters and that does cause damage, although if I'm weighing it against compliance and volume, it's not as much. So, but know that you're not getting something for free there. Stress index. Who uses stress index here? Dr. Bartok, of course. So stress index it's a cool concept and it's free. Like this is why I love free things you can check very, very quickly. So the concept of it, so here's the caveats to it. You have to have the patient in volume control and you need to slow the flow down as much as possible so you can see this part. So as this is the pressure waveform, so you can really see an extended version of the pressure waveform. Now, your stress index, when it's normal, when you have relatively, it's a normal looking stress index, it's 1, what you'll see is that as my volume is coming in and my pressure is rising, for every cc of volume that I'm getting in, I'm getting a linear rise in pressure, right? So it's kind of proportionate to each other. Now, if I'm overdistending, I'm putting in volume, so every cc is proportionate, and all of a sudden, my pressure rises up exponentially compared to my volume. What have I done there?
You've overdistended.
Overdistended. Yep. So that's why, so this stress index is greater than 1. And that tells you that either you reduce your tidal volume peak or something, you're overdistended. This one, I'm adding tidal volume in, it's going in, pressure looks beautiful, and all of a sudden at the tail end, I see that for every given cc I'm putting in, the pressure is not rising at all. That tells me I got room to go, right? I can increase my PEEP or increase my where I can try to get it to a stress index. I don't have to, but that may tell you that you're getting some atelic trauma. You may have some closed alveoli that you could potentially recruit. Right? That's good. And the way I do it usually, as I said, I'll grab. I slow down the speed, I drop the flow rate to nothing, I put them in volume control, and literally I'll just take a piece of paper and I'll see where it looks compared to the piece of paper. But the actual study for stress index, they actually had a computer or a software that actually looked at calculate. So one of our events, the servo, some of them will give you a stress index on it. So if you have a servo, you can ask the RT, can you give me the stress index on it? And they'll be able to give it.
Wait, so you just look at the pressure volume curve though?
No, I look at
You look at the
pressure waveform.
Oh, you look at the
You can
pressure
look at the
waveform.
pressure volume curve, but I can just look at the pressure waveform. And the pressure waveform is always there.
Yeah.
It's always there, right? And so I can just look at this, and this is what you'll look at. And so you have your pressure, volume, your pressure, flow, and volume, right? So you just look at the top one.
But you gotta remember to switch them back to PRPC if you play with
Yeah.
it.
Before you get in trouble. We don't want to get Dr. Bartok getting some calls later. So just another illustration of, and also it has to be, I forgot, it has to be in square waveform. And so why does it have to be in square? Because you're getting basically you're getting a linear increase in volume, right? So slow linear increase is how you're going to tell on this. And so again, stress index less than 1, you can probably recruit, and you're probably over here. Stress index, so it's exactly the same as the pressure volume curve.
Yeah.
It's just, I think it's actually even more intuitive than the pressure volume curve.
Okay.
And you have to pull the diameter up. Here, you're in the sweet spot, right? Above the lower inflection point and below the upper inflection point. Here, you get that bird beaking. Have you ever heard that term, the bird beaking? Where so your volume is rising, but all of a sudden I'm getting an exponential increase in pressure. So when you hear the RT say that there's some bird beaking there, it tells you that you're over descended and you probably need to come down either your peak or your tidal volume. And this is how your stress index is going to look there. Right? Right, so conclusions. Understand that not all ARDS is the same. Know that there's intrapulmonary and extrapulmonary ARDS. There's chest wall component. Your respiratory system is both made of your chest wall and your respiratory system. Understand mechanical powers and know the complexities of all the variables that you're going to change, right? So when you're increasing the rate, understand that it's not a free lunch and you're causing damage to that as well. And if you have room on your pH, don't change the rate, right? Just either come down on top. The rate matters, so take advantage of your pH limits. Get down to that 7.15. That number looks scary in our head. For some reason in our head, 7.19 is really scary. 7.21 is not, right? We get alarmed at 7.19, and I bet you could do a study where you take 7.19s and you take 7.21. There's vastly more interventions in the 7.19 than there is 7.21. It's just a 0.02 difference. It's really literally it's just like no difference. So, but 2 a.m. that's hard to think about, right? And so I get that. And just know that you have a lot of tools and a lot of ways to understand what the best PEEP is, what your best tidal volume is, understand the concept of stress and strain, stress and strain, and then really understand what transpulmonary pressures are and how they're going to be different. That's it.
So this might be a recurrent question in literature, but I was wondering if there is any benefit in mortality or morbidity for proning non-ARDS patients.
That's a great question. Yeah, so, but to that I will say is that why? If you're not recruiting, so by evolution, I was saying that you should get some benefit no matter what, right? Because like you are, if you've been laying down for a while, you'll have some edema. And we know that your ventral units are bigger anyways, and in gravity you can move it over and cause more VQ improvement, especially. But you ask yourself, are you going to get any incremental benefit? The opposite, I'm going to give you a devil good advocate answer to what you're saying, is that if I, at any given plateau or transalveolar pressure, so let's say this is 25, I'm happy with it. Proning, does it increase or decrease your pleural pressure? Your proning, does it increase your pleural pressure or decrease your pleural pressure?
Probably increase.
Increase. But you're right, I was wrong for many years. It's counterintuitive for me. I was just thinking, oh, I'm taking that big belly and I'm loading it on my pleural pressure will drop. That's what was going on in my head. In reality, your pleural pressure goes up. So the pleural pressure is rising. So at any given, you may recruit some of this. So whenever I've heard some of you guys say is that I proned them, but I didn't see any improvement in compliance. I didn't see any improvement in driving pressure. You may not, because this is what you're seeing, and you may not see much of a difference here, but you're going to get increase here, and your transpulmonary pressure will drop, right? And so if I had someone with RV failure, I may prone them at a PDAF of 250, right? And they have some lung damage, not that impressive, not enough to say, but I could have that conversation there. Then maybe we should prone this person, reduce their RV afterload, because positive pressure is horrible for the RV and it causes damage over time. So there's no study to suggest that, but you're the expert. If you're the fellow, you're the expert, and your job is to think between the paper lines and understand the physiology and how you can individualize care for your patients. So it's not a crazy thought. Cool? All right, thanks.